So when you're proving your brain injuries to a jury now, and when you're talking to a jury of Generation X or Generation Y, we prove everything, every aspect, every little aspect of a case. There's a mistake that I've seen lawyers make for years, and I've railed against it for years, in that when you have a large injury, you have a substantial injury, you have a tendency, like if you have a paraplegia case, for example, you have a tendency to forget all the other injuries and just focus on that paraplegia case. So what I would always do when handling paraplegia cases or anything else is I would take one of my associates and I'd say, okay, your job is to prove up every injury to this patient except the paraplegia. So you take this patient as if they have everything wrong with them except the paraplegia. So then you get all those small injuries, they have a way to add up. So in a brain injury case, we like to show everything that indicates a contributing factor to a brain injury. So here we're talking about damaged brain cell. Now we have a left skull fracture. Okay, then we prove the left eye scalp laceration. These are not big things in and of themselves, but they're all just, again, indication of the blow to the head. The periorbital laceration. And then we get the injuries, we get these blown up, and this is post-traumatic polycognitive deficits of memory, judgment, insight, and executive function. Then, when you want to engage the jury, you want to educate them. The question about how can you get hit on one side of the head and have injury on the other side of the head, which we know as diffuse axonal injury. So we created this graphic to illustrate that point. Now this is where you put your doctor on the stand, and I mean the doctor's up there by the picture, and he's pointing and he's saying, okay, you get the blow to this side of the head, the brain collides with the skull, it shoves across, the brain collides with the other side, and then your doctor, this is the part where you want your doctor being the expert. You can freeze frame this anywhere you want to while the doctor explains what the axon is, what the neuron, the myelin sheath, and he shows the transfer and then shows what happens. Now you'll see the bump here. Okay, that's where the shearing occurs. That's where the blow to the head occurs. And now you have the axonal shearing, and you no longer have the compromised signal. You have a compromised signal transfer, so you no longer have the normal transfer of information. Then the doctor follows up on this by saying, okay, what does that mean? What is the effect of that? That's a nice graphic. Okay, so you have compromised signal transfer. So what? So now your doctor just takes the next step and explains, well, here's what happens as a result of that. Here is what happens functionally to the patient as a result of that. So we cover those injuries, and then we go to film, and we do an MRI of the brain, and you walk through the injuries as they occur here, and you go deeper and deeper into the injury, and then here's the MRI of the brain. Now you have to understand that with this child, the neuropsychologist, the defense neuropsychologist who did the examination on this child, his finding was that this child suffered a tendency to stumble, which probably predated the accident. That was his finding. That was the defense in this case. So we got into all these MRIs, and in this you can break these down, and you can show all the various, you can go deeper and deeper into it, and this starts with contusions. But when you get to the sagittal view on this one, what you see is a void in the splenium of the corpus callosum. So what you have is a hole in the brain, in the part connecting the two hemispheres. Now, that may have a little something to do with the stumbling too. So this is the graphic, which you can do, but then this is the actual MRI here, and that shows up rather graphically. So the next thing, we brought this young lady down, and we had this was just becoming, we brought it down to Texas Children's. This case was in Arkansas. I had this big 18-wheeler case in Arkansas. And I brought this young lady down. I called the doctor over here who was doing the DTI at the time, and I said, look, I got a perfect case for you. And she said, bring her on down. So we brought her down, and I wish this showed up better. This shows up beautifully graphically on the originals, but it doesn't translate to slides to this very well. So it's much too dark, but you can probably see it. This is your normal brain fibers of the 8-year-old. You see the colors in here? What they've done is they've color-coded the brain fibers. So this is your normal 8-year-old, and you can turn this around and you can see it from all sides. Okay? Now, this is our client, and you see what's happening here? There's a void here, there's a void here. And this is where the brain fibers are dead, basically. And then we can turn that around and we can show it, and we can stop it wherever we want to. So this is the DTI. So we brought this down, and then the result was just, I think, excellent. It's a beautiful illustration. This is your PET scans, and the way we show this is just by pulling out markedly decreased F18, so forth. And then the same thing on the SPECT scans here. So we created those. Now, I've worked for years in these mild brain injury cases where I was trying to figure out the most effective way to convert a neuropsychologist report. We get neuropsychologist report, and it's a lot of paper this thick. And it has a lot of names and a lot of tests and a lot of this and a lot of rather simplistic tests, it appears. So, but you would absolutely bore boomers and Gen Xers and everybody else with that. And I say that from experience. But Generation Y would never even, you try to get the millennials to sit and listen to a neuropsychologist tell you about the brain injury to this child or to anybody, and they're not going to do it. So you got to find a way to get it, make it interactive, to make it so you can, it's all, third grade school teachers figured it out a long time ago. It's all about show and tell. And so you really have to show and tell with more emphasis on the show. So I worked with Dr. Pollock and with Dr. Lilly and with High Impact Graphics in Denver, and we came up with this method of showing the neuropsychological testing. You notice down here, this is severe deficit, moderate deficit, mild deficit, low average, average, high average, superior. Now up here are each one of these are the various types of tests. So what you do is you put, again, you can get your doctor to the stand and stand there and point to each one of these and explain it, and they become the educator. So first the doctor explains what the intellectual functioning test, what these tests are, what they are designed to show. And then you notice down here in those testing, you have 1% sequencing speed, lowest first percentile of sequencing speed. The visual attentions, 6th percentile. Processing speed, 8th percentile. Working memory. So you go through and explain what each one of these tests is, what it's designed to show, what does it mean to have 1%, to be in the first percentile in sequencing speed. Then you go through the next testing, the verbal learning. And these are the verbal learning tests, and 2 out of 3 are adverse. Then you go over to response inhibition and sustained and focused attention, and then you get to executive difficulties. And when you get to the executive function, this is about as severe as you can get in executive function. And they have this one here, particularly high. Oh, well, she's doing superior on that. No, wait. That's the at-risk concerns in daily living. So that's where you want to be down at 1/2 of 1%. So by the time a jury starts seeing all this curl along here and see first percentile, 6th percentile, and so forth on all these, 3 percentile, 2, then they start getting the idea that this child does in fact have some brain injury. And this has been the best thing I've been able to come up with so far in terms of establishing what the nature and extent of the injury is in this type of situation. Your starting point for proving a brain injury is this. Before you prove anything else, you prove this. What is this? That's the vehicle. Now that speaks volumes. Without saying a word, that speaks volumes. That's the car. If you can make out what the car is like, it was hit head on by an 18-wheeler. So in the right front, you got the mother in the driver's seat. You got the child immediately seated properly behind the mother, facing backwards as they're supposed to be. You got the other child in the back seat. You got the father in the right front seat. But look at the nature and extent of the injury to that vehicle. So right off the bat, it becomes very easy to believe that there's some pretty severe injuries involved in here. We also prove up the surgeries. And surgeries don't seem, some of these surgeries, you say, well, we had a repair of an open, depressed, comminuted skull fracture and a placement of a ventricular drain. That doesn't sound like much, and it's really not until you see it and you have the child sitting in front of you and you see what it looks like, and they move. The jury gets a chance to see especially the drill bit making the hole in the skull, and they're watching this little girl sitting there and thinking about, okay, all this happened to her head. I mean, this is a simple surgery, but again, all these simple things add up because these are all things that the child endured. And these particularly come because people kind of grimace. We've shown these to focus groups, and people kind of grimace, start putting staples in the head and that sort of thing. But then when they take the drill and start making the burr hole, that always has a certain impact. The people kind of grimace when they get to the burr hole. And again, this is all part of what an 8-year-old child endured. And the reason she had to endure all this is because she had a traumatic brain injury. So this slight tendency to stumble from the neuropsychologist for the defense sort of fell apart on this pretty rapidly. When we got through with this, after this case was over, the defense lawyer asked me if he could use my graphics, if he could take this demonstrative evidence and use it to give a speech to the defense bar. I said, well, if you'll stipulate, if the conclusion of your speech is you better damn well settle with Howard Nations, you're free to use it at will, any time you want to. We had other cases in here, and this is just to show we had 4 people, we had 4 injuries in here. The child was killed, and I think the size of the casket here just sort of tells the whole story. You don't need a lot more than that. We also did the calendar in here showing 83 days of blank pages, 83 years, I'm sorry, 83 years of blank pages for activities of daily living. Then there's another one here that I'll show you just for a moment. This is where you have the severe trauma and where you do the full body graphic. And I did the same thing here. She had diffuse axonal injury. She had the scalp hematoma. And again, we bring out everything. We illustrate everything, regardless of how slight it may be, because, you know, after a while, the jury starts seeing all this and it starts adding up. And but there are things in. Look at all these fractures. Each one of those little gray boxes, you can't see it from there, but each one of those gray boxes is a fracture. A fracture to the face, which again goes right back to its skull fractures or facial fracture, which goes back to if you got hit that hard in the face, you broke all those bones in the face, think of what you must have done to the brain. And then we covered arm laceration, femoral fracture. In the femoral fracture, you know, people talk about they put a pin in the leg to repair the fracture. We go through all these rib fractures, pneumothorax, sepsis, and then we get down to the surgeries. When people talk about, well, they put a nail, had a fixation of the nail in the leg, and that doesn't sound like much because a nail is something about that long that you drive with a hammer, right? No, not exactly. So we have to show what this actually consists of, making an incision, drilling up into the bone, putting this kind of nail. The whole idea of drilling up in your knee and up in the bone. This doesn't look like that much fun anymore. So that's what a nail looks like. But if you take each one of these things and break them down, and each one of these is educational. Each one of these tells people the nature and extent of this woman's injury. And each one of these also contributes substantially to her overall damages, but it doesn't leave much doubt at all that this lady was the victim of a traumatic brain injury. Remember this, try the case you have, not the case you wish you had. And so in his case, we didn't try to claim that he had a multi-million-dollar claim. We proved his case for what it was. And what he did have was executive function. He had damage to executive function. So then we were able to prove mostly gray lines all across, mostly gray, mostly up here, mostly high percentile. But then we proved that he was highly functional except where he wasn't. And where he wasn't were in these columns over here under executive function. Then we had to explain what is the loss of executive. Well, loss of executive function, as you know, can mean an awful lot of loss of coherence in your life. So that's how we approached a brain injury case, and how I think that we have to approach brain injury cases today. You have to involve your jurors today. You have to be interactive with your jurors today. They won't talk to each other, so they're sure as hell not going to listen to you. So what you do, and I finally figured this out, what you do is you determine what your message is for your final argument. And when the judge says, all right, Mr. Nations, you may proceed, you take your final argument and you text it to them. So I hope I've said something that will help you help your clients. Thank you very much.